Professor Simon Heller, our main speaker tonight. Welcome.
Thank you, Brenda. Very kind of you. Okay, as usual, it's a pleasure to be here. July is my usual slot, although I made a mistake last year and had to delay it. But today I am here, luckily. And I usually talk about research, and I'm going to do just that. I'm going to talk about studies we're doing and concentrate on one particular trial, which is just about to start and which we are world leaders in, which I'll explain. I think Ahmed Iqbal, my colleague, who's helping me and co-leading it here in Sheffield, probably mentioned it earlier in the year, I think. And then I'm going to talk a bit about some of the other studies we are actually doing or planning. And as Lindsay pointed out, there is real opportunity for people to participate in our studies. People who participate in these studies, even if they don't get an active treatment, do better just by being part of a standard research study, following the protocol. Their outcomes are better, even if they're not getting the active drug. And I don't think that's always obvious to people. But as I'll go through, I will talk about those studies in detail, what their aims are, who we're looking for, and if you know people who aren't here tonight who you think might be interested, that would be great. And both Ingmar and Deb are going to talk on the back of some of the work that I'm going to be describing. So, does this advance the slides, or should it? The blue light is. No? Oh. I didn't do that, did I? I just pressed the arrow. Right, fantastic. So the questions we're going to answer are these kind of trials, which I'm going to talk about. I'm going to start on the CLEAR trial, that's one on hypoglycemia, and then I'm going to talk about some of these studies, which are type 1 diabetes, and also ones which are about nerve damage in diabetes neuropathy, as we call it. And I'm going to finish by talking about what's becoming one of the scariest new things in diabetes, which is actually type 2 diabetes in a specific age group. And I looked through your program. I don't think this has been talked about in detail, but I've been reading about it, partly because I do our young person's clinic. We have people with type 2 diabetes, and it's really a new condition, I would say separate, very different from standard type 2 diabetes, and it may cause devastating complications, including the UK, but particularly in developing countries, lower middle income countries, as I will explain. Okay, did you advance them? You may have to.
We had somebody just joining us on Zoom, so I have to trickle through.
Oh, okay.
Link.
Okay, so this is the CLEAR trial, and it stands for Closed Loop and Education for Hypoglycemia Awareness Restoration. Bit of a mouthful, but CLEAR is something which I think would make sense. And the problem is this, a condition called impaired awareness of hypoglycemia. It affects people on insulin, both those with type 1 and in type 2. In type 1 diabetes, around a quarter, the whole adult population with type 1 diabetes, which in this country is around 250,000. So we're talking 50,000 people lose their warnings of hypoglycemia, partly because they've had diabetes a long time. But as we showed in studies I did in Nottingham, and then when I went to America to do a study, we showed that one of the most important causes of losing your warnings is repeated episodes of hypoglycemia. And what happens is that the body's defenses to hypoglycemia, many of you will know that that is adrenaline, release of adrenaline, and the stress hormone, It can give the symptoms of tremor, shaking, palpitations, and those symptoms will get less and less and less, and they don't come on till your glucose can drop to 2.5. And as you get older, the threshold at which your brain begins to stop working moves from 3 up to about 3.5. So you can see that if you have repeated episodes of hypoglycemia, particularly those below 3, you can reset your defense to a level which is lower than that for brain dysfunction, which explains why people can get the symptoms, indeed their relatives recognize them, but they are unaware. And it's relevance that in type 1 diabetes, it increases the risk of severe episodes by 6 to 10 times. So the people who've lost their warnings are the people really at risk, and it has other consequences. If you really lose your warnings badly, you will lose your driver's license, although of course, more than 2 episodes of severe hypoglycemia, defined as needing the help of another person to recover, is another thing. And type 2 diabetes, 10% of people on insulin with type 2 also lose their warnings. And there, the risk of severe hypoglycemia goes up 10 to 15 times. So you're identifying a very high risk group of people. After our study, which we published in the early 90s, we hypothesized that if you could stop all hypoglycemia, maybe you could get your threshold for the adrenaline release to move up again and restore warnings. And actually, we showed other people had showed that. So it is possible to get the warnings back. But interestingly, it doesn't come back completely. And so what we decided to do is to say, well, what would be most effective? Could the, is anybody on a hybrid closed loop here? Yeah. So that is the most modern treatment, and it's being rolled out, well, to start with 150,000 people, adults in this country. At the moment, all young people under the age of 21 with type 1 diabetes are entitled to have a hybrid closed loop. And they keep it. But for people who are already older than 21, they have to have a high A1C. For those of you who manage to manage your diabetes and keep your glucose levels close to target, I'm afraid you're going to be at the back of the queue, which doesn't seem very fair, but that's what the government have decided. But I would say within 5 years, everybody who wants one with type 1 diabetes will be in one of these semi-automatic pumps. For many, they are transformational. If you're brave enough to let the machine do the work, and you remember to tell it when you're going to eat, ideally 20 minutes before, and when you're going to exercise, it will just get on and do the job for you. And it's a remarkable, and there are four or five now different systems which you can go on, which we are offering. But even more interesting, we've been involved with educational programs.
Sorry.
Oh, it's okay. Are you going to chat away, Lindsay, or should I carry on? Okay. Educational interventions. I'm sure some of you have done the Daphne course. If you just go on a Daphne course, it reduces your risk of having severe hypoglycemia by 80%. So a huge benefit. Ian, how nice to see you. And so, and even more interestingly, we've used 2 educational interventions, one called MyHypoCOMPaSS, which we did a trial on about 5 years ago. And we've used another one called HARPdoc for people who find it very difficult to change their behavior and reduce their risk of hypoglycemia. So these 2 educational interventions have been very successful. And even more interestingly, they are more effective at restoring warnings of hypoglycemia than hybrid closed loop. And we don't know why. So what we wanted to do is to compare educational interventions against the technology. And so very luckily for us, the Americans at something called the National Institute of Health, which is in Washington, in America, decided to offer money, a lot of money, to do a trial. And so we wrote in our application, and then they chose the 7 best who got the scores, and then they put them in a room and said, right, come up with something you all agree with, which is a pretty stupid way actually to design a trial. But we weren't going to turn down $3.5 to $4-5 million. So we agreed. And the great thing is they agreed to do our design. So I am co-leading it with a friend and colleague in Minneapolis in America called Betsy Sequist. And we're leading this trial across the world. So these are the educational courses. Some of you may even have done HypoCOMPaSS. It was led by Jim Shaw from Newcastle, and we recruited people who'd lost their warnings, as I said, 5 years ago. It teaches people behaviors to avoid hypoglycemia, to treat themselves, to recognize early symptoms, being aware when they're at risk. And you can see it takes about 5 hours over 3 sessions. So that's one. And the other one is HARPdoc. That's something that even people who've used technology, including hybrid closed loop, can still have problems with hypoglycemia. And Stephanie Amell, my friend and colleague in King's, who's very well known, she designed it with a clinical psychologist, Nicole Besoisa, who works with us actually in the Daphne research. And it addresses unhelpful health beliefs and the way in which people respond to the risk of hypoglycemia. And it uses something called motivational interviewing and cognitive behavioral therapy, psychological approaches which have been very successful, for example, at treating depression. That was tested in another trial and shown to be as effective as an American kind of educational course. But it really improved people's quality of life, diabetes distress, and those are the two that we're comparing against the technology. Oh, did I do that? No. So these are the questions. Does hybrid closed loop, if you keep it going for a long time, and you can see in our study it'll be 2 years, lead to restoration? The theory being, if you can stop all hypoglycemia, eventually the brain will recover. It may not recover because, of course, if you've had diabetes for 20, 30, 40 years, in the brain which fire off if you become hypoglycemic, and that's what triggers this whole thing. Maybe they're damaged. We don't know that. We can't do animal studies, obviously, in humans by examining their brain. So that's one of the things. Are these educational interventions more effective? Because what we want to do is find a treatment that everybody across the world can have. And then can we identify people with certain characteristics, duration of diabetes, for example, one treatment. So this is what we're going to do. This is the trial. It's very large. It's the largest ever study. I don't think a study like this will ever be carried again. And it's and you know, it's a lot of money, which we are very lucky to be having. I have to tell you that we were quite worried when a certain change in president occurred in America, because he was cutting off money to foreign countries, and we were very scared that he was going to cut it off. But if he did, the whole trial would collapse, because it's actually our design that we're doing. But so far, and we're just about to start the trial, so it's still okay. So we're recruiting over 300 people across the world, and you can see there 1, 2, 3, 4, 5. 1, 2, 3, yeah, 4, 5 sites in the US, 2 sites in the UK, Sheffield and Leicester. And Professor Prateek Chowdhury used to be my research fellow. He was working with me when we persuaded him to do diabetes, and he's gone on to work and is now a consultant at Leicester. And we got one investigator in Australia, in Melbourne. So the aim is to use new technologies and educational courses to restore awareness. And we're dividing the people to people who are already on hybrid closed loop and those who've never used it. And we're going to compare it to an educational intervention and see which works the best. And the test is quite involved, as you're about to see. And this is hard work to be in this study. 20 visits over 2 years, of which 13 are by phone, and it includes 3 clamps, hyperinsulinemic hypoglycemic clamps. And I was going to say I'm proud, but we were the first people when I was working in Nottingham to invent the hypoglycemic clamp, and I'll explain what it is. But essentially, you come into the clinical research facility, you have various tubes put in your veins, and we give insulin and then lower the glucose from a normal hypoglycemic level, and we make lots of measurements. And the one we're really interested in is how much adrenaline you make at a glucose of around 2.5 millimoles per liter. So that's what we call moderate hypoglycemia. It's not severe, but you do feel a bit rotten when you have it, at least if you don't have diabetes. And I know that because I was one of the subjects who kind of tried it out. And yeah, you sweat a lot, at least if you, but when your glucose comes up again, you get better. So we're going to essentially compare the two. We will be measuring continuous glucose monitoring because we want to know how much hypoglycemia people are having. We're going to get people to wear activity monitors and find out how often they spot their own hypos, and that's what we're going to do. And you can see the educational sessions are also quite a lot as well. I should also say it's not an incentive that we are paying people much more money in the UK than we would ever be allowed to. The Americans are much more free, won't we? And so I think people will be paid around £2,500 in this study, but we don't want, that's not why we want them to be in the study. We're not going to pay people as a bribe. That's for loss of their time. And so that's part of that. And as we've written there, this is tough. This is a hard study, but it's unique. It's the only study which will ever be done like this. So this is what a clamp is. And the first ones we did were on each other when I was working in Nottingham. And essentially what you do is you give insulin and you then have to give glucose through a vein to keep the glucose at normal levels. And then once you've done all your tests to start with, and they would include doing a reaction time test because you want to measure how the brain is working at the level at which it begins not to work as well, because reaction time will get longer. We measure symptoms. We ask people to score their symptoms, and we keep it a secret what the glucose level is because we don't want to influence them. And here you see the example of a clamp. You can see there's drips going in, one to give glucose, one to give insulin, and then we have a little vein on the back of the hand, which we keep in warm, and then we take blood samples out, small amounts. You don't lose huge amount. They'll have no blood left at the end of this, but it's not a huge amount of blood. And of course, we have to get through a committee who says this is safe, although they agree with us that it's going to be not a study that everybody will want to do, but it's one of a kind. So who is able to be referred, well, you have to be between 18 and 75. You have to have type 1 diabetes. You have to have had diabetes for longer than 10 years because you want type treated for a long time. And they have to have impaired awareness. And we test that by giving them a scale. And we ask them questions about how they recognize hypoglycemia, what level they get it. And that will give them of a certain sort. Those people have impaired awareness, and they're the ones we will be interested in. They have to have not fantastic glucose levels. They can be quite far from target, 91, and they have to be able to understand and speak English. So that's the referrals. So we're looking for these people doing a 2-year study, which will be quite a commitment. But the benefits are, for those who aren't using hybrid closed loop, they'll get hybrid closed loop and they'll keep it. So that's an incentive, but I don't think that's why we want people to be in it. We want people who've got a problem with hypoglycemia and would like to be fixed if possible. These educations are not available on the NHS, although we have participated. And this already reduces hypoglycemia burden, but what we don't know is is it best to do it in combination? Is one much better than the other? Education versus technology, and that's really what the trial is involved. So that's it. I'm happy to answer any immediate questions about the study, and then I'm going to ask Ningmar. And I had to write a letter of apology to him because this was already a tough trial, but we wanted to use his approach, test his approach, which he's going to tell you about in this. But the other people who I'm working with in America said, oh, I think this is going to be too much work. But we've got a backup plan she and I have discussed. So hopefully we haven't wrecked his research. But yeah, I was really upset when they said it was going to be too fit. I disagree with them. I thought it was not going to be easy, but it wasn't. So any specific questions? Yes, please.
Considered having an arm where you look at both education and the other options basically together and see if there's an additive.
We have. I was going to show you the study design, but it's fiendishly complicated, and I don't even understand it. I do actually, but it's very complicated. So we've got 2 arms. We've got people who've never used hybrid closed loop, and what we're going to do with them is randomize them, like toss a coin, although a computer does it, and they either get what they're already on. They could be on a standard pump, they could be on multiple injections, and the other group will get hybrid closed loop only, and we know that will reduce hypoglycemia. So, and that was the MyHypoCOMPaSS, the more simple one of the educational. So we're going to compare those 2. That's in people who aren't on hybrid closed loop already, what we call the naive, because they've never had it. Now, people who are already on hybrid closed loop, they've been using it for a time. So we want to do with them is just have them on it longer. In America, you go on hybrid closed loop with no education or training. They don't believe, well, actually they do believe in structured education, but they have no clue how to do it. And some of them in America say, we'd like to bring Daphne over. And then I'm told, oh, we can't do it because educators do it. There's no working together, doctors, nurses, and dietitians as they are here. So they will be on hybrid closed loop for longer. We will keep them on for an extra year. And those who are already on it, half of them will get MyHypoCOMPaSS. So we will compare a combination, because you're absolutely right. That's what we want to know about. And at the end of that year, we'll then randomize some to the HARPdoc, which has been shown to be extra beneficial. But it's really the first year which we're really interested in. Does that answer your question? Thank you. Ian.
For those on hybrid closed loop, will they all be on the same device with the same targets?
They will be on with the same targets, but again, for reasons of insurance, it won't be the same. We are very lucky because I don't know, is anybody on Omnipod 5? Yeah. So the OP5, well, I've tried that and the tandem system and I didn't like the tandem system much, but the OP5 is really good, but you have to be on less than 100 units of insulin a day because that's how much it takes. But Somedic are giving us them free. So we are very relieved to that. And that, so, but they didn't want everybody to be on their pump because it would have used the world's, I mean, we wouldn't, but so people who still on their system, that can be a Medtronic 780, that they could put CAM-AP, some of the other systems, they can stay on it if they want, but we definitely set the same glucose targets. It's a slight disadvantage, but in America, they can't afford to pay people off the one they're really paying. So that's, yeah, and yeah. Yeah, you really ask it. Lindsay?
But mine is comments that I did the HypoDoc participant. It started before 2020 and then we had to pause it for a while.
Oh, the HARPdoc, yeah.
They were confident, and not just around hypo, but around diabetes generally. Yeah, I think it was massive.
Yeah.
Being up like that, something was they told me afterwards that they scanned my brain before the course started and then after, and they said there was they could see there was a real improvement in the brain.
Oh, you did the one at King's. You went to King's at the scan.
And
You see, Lindsay survived. Anybody can do one of them.
thing where you can.
Yeah.
Yeah, I did that. Just
Well, I'm sure we can find different food that's really.
that really careful and cares about.
Yeah. Yeah, so and you know, and these are hard studies, but my MD back in Nottingham in 1987, when I was doing it, I managed to find 25 people who were the first people in the world to have a hypoglycemic camp, and I'm pleased to say they all survived. So it was all right. Yes.
I imagine most of these patients would already be on CGM, given their history.
They would.
And some will be on Dexcom and some will be on Freestyle. Dexcom has predicted you.
They do. Well, we are letting people stay on their same systems. But what we are doing for those who are not using a Dexcom, we're giving them a 6-week period with a blinded Dexcom, so they don't know what the results are. They will be on their Libra, let's say, as well. But we clearly want to find a period where what's really interesting, we did another study, which we've finished now, a European project, which was called HypoResolve. But in that, one of the arms, we used this app where people who had hypoglycemia, every time they had a low, they had to fill in what symptoms they had. And the CGM was also detecting hypoglycemia, and we found massive difference between people's lows that were detected, that they detected, and the ones that the machine did. And what was really interesting is that the ones that they didn't notice but were being recorded had very little effect on their quality of life. But the ones that were detected, particularly in the night when they had to get up and take action, the people who were having more of those, it was having a really detrimental effect. And of course, I'm talking to people who know, but it wasn't necessarily that the brain was being affected, it was just the interruption in your day, which was just getting in, and just yet else gets in the way of your life. And that was very negative psychologically, which was fascinating. So we were going to record all those and see what happens. Brenda?
Did you say that certain side end of some of the people having going home during the night and knowing
Well, it could have been that. It could have been the insulin was just them waning and coming up. Everybody with hypoglycemia has lows they don't detect. And, you know, even though they think they know, and that happens in type 2 diabetes, we did a really fascinating study that Elaine Chow did. We found that their heart rates change during the night with type 2 diabetes. And sometimes they were low for 5 hours, running around at 2.5. Of course, type 2 patients with type 2 don't get CGMs, but it was really scary to see how much hypoglycemia they were getting at night. So yeah, it happens a lot. And of course, we have shown evidence that that is not good for your heart as well. And actually that has changed practice across the world. People realize that hypoglycemia isn't just not good for your brain, it's bad for your heart as well. Sorry, yes.
I was just making a general comment.
Yes.
It seems a bit frustrating since we can't speak English.
You're right. And actually in the States, because they have a very big Hispanic population, they are including people who can speak Spanish. And I'm sure if we did have somebody, we could. I think it's a real weakness for us, but I won't tell you how much money it's already costing and translating everything. But I think that is a weakness, and I absolutely take your point. It's really important. But hopefully, many people with type 1 diabetes, I think, would probably speak English, but I accept your criticism. It's well taken. Right. So no more questions. Ning, do you want to, it's a good time for you to tell people about your study because it's hypoglycemia. I'm not really going to talk about much hypoglycemia, but anybody who knows somebody who's interested will be delighted to talk to them. Okay, over to you two.
So I'm not a diabetes consultant. My name is Marshall. I'm based in computer science school at the university, and I share my time at Sheffield Teaching Hospitals working on AI for health. You probably heard this AI, the buzzword, lots. But my interest is in speech and language technology. So I'm very interested in how we can apply technology and acoustics and using that as a tools to help diagnose different health conditions. And at the Sheffield Teaching Hospital that I'm working on trying to bring AI into the trust, trying to make our hospital more efficient and trying to help solve different challenges faced by the NHS. So today, I'm going to talk a little bit about the project we about to launch, we're running at the moment. So the whole idea came with last year. I was in the same meeting with Simon that I was talking about the AI voice and speech and technology, and Simon be talking about diabetes. I thought there's actually some studies showing your voice changes when you blood sugar goes high or goes low. So we developed this project. Yeah, thank you. So this project is in collaboration with Simon and also Nick, who's a diabetes consultant based in Imperial College, and Oliver is here with me. And so we managed to get a small summer project funded by the university to do a pilot study. So Oliver is working on that. Also working, I want to acknowledge the Device for Dignity, the NHR Health Tech Research Center, who's part of the project. Sheffield BRC, the Biomedical Research Center, is providing some funding potentially to do PPIE later on. And I'm really grateful that Diabetes UK and Sheffield team has been working with us, and we had a couple of meetings already to discuss this project. I want to move to the next slide. So I won't spend too much time on this slide because you'll know really well the there's a short-term consequences of diabetes. There's hypoglycemia that's Simon talked about when your blood sugar goes low, and hyperglycemia. But also I'm looking at the long-term consequences of having diabetes, which involve neurological impact. For example, your fingers, your legs become numb, has a lot of impact on your vision. Cardiovascular disease has a big correlation with diabetes, kidney failure, and fetal limbs, etc. So if we move to the next slide. So managing diabetes really effectively, we need the tools that can regularly monitor our blood glucose level. And so currently, that involves finger pricks, which is very commonly used, but that's quite inconvenient in that it's very difficult to do it regularly, and it's not a nice experience. Luckily, we have this CGM. A lot of people have CGM in the UK, especially if you have type 1 diabetes, which is fantastic. But CGM is still quite costly, and it's not available in every part of the world. And at least in the UK, you have type 2 diabetes, you don't get a CGM. So if you could jump to the next slide. So I'm just from the conversation with Simon, I'm very kind of interested in hypoglycemia, especially when there's a kind of increased risk of cognitive decline. I mean, generally, there were some studies showing when your blood sugar goes low or goes high, that changes voices. I'm showing a picture here. So think about how you speak, how you communicate with other people. That's really originated from the brain. So you have to form word in your brain, so the message you want to say, and then in order to produce speech, that requires your muscle around your chest, to push the air out of the lung into, that's the vocal cord is really generates the sound, the energy, so that vocal cord vibrate. So that generates the pitch, and then as the sound wave go past the airway, so this form what we call a filter or a sound box, essentially, that produce resonance and give you different. So you can monitor that shape by changing the shape of tongue or force the air to go through your nasal canal, and so that therefore you can generate different vowel, different nasal sounds, etc. So I think when your blood sugar goes high, that could potentially affect the vocal cords, the muscle, and the vocal cords become drier. So therefore, from the acoustic point of view, the sound may differ. But also when when hypoglycemia happens, when you have cognitive decline, you start to also become for example, feeling dizzy, and your speaking rate may slow down. You may forget what you want to say. You may increase the pauses between the words. And so there's all kind of different aspects acoustically and also from the linguist point of view, that there could be a different factors that will be affected by diabetes. So we are interested in using a voice as a biomarker for detecting the blood sugar levels. So what is biomarker? Is really something that can be objectively measured and used as a surrogate marker for a clinical endpoint. So in this case, we're looking at the voice as a biomarker. So voice produced under different pathologies really differ from the voice produced in a healthy state. So I'm giving an example here. So on the top, the green bit, what we call the waveform. So this is what you record, essentially the energy of this air vibrating. So that's being recorded by the microphone. So this is the time. So that the side of the green line that indicates the energy, the volume of the voice. That's what we call a spectrogram. That's very similar to how the ear perceives the sound. So here you have a time in the x-axis, then you have the frequency along the y-axis. So this is high frequency, there's a low frequency. So that sort of lines, that's what we call the fundamental frequency. So there's a harmonics. So the energy indicates what we call the formants. So that's how when the sound starts resonance during the speech production. So that detects whether you hear a R or E. That position of this formant would vary. So that's what we call kind of normal speech. So you can see it's fairly energetic. You can see a lot of details here. But if you look at the speech on the right-hand side, that's kind of a tired speech. When you're very tired, you don't have a lot of energy. You notice the volume become quieter, and also the form and shape become flatter. So you basically you just sound you're very tired and just don't want that energy. So we think that could also when you have a hypoglycemia, you may have similar impact. So that's sort of cues we'll be looking for in this study. To the next slide, please. So like I said, I've been looking on the voice and breathing sound acoustics as a biomarker for different studies. There's a lot of studies showing using speech as a biomarker for example, detecting Alzheimer's disease. And with this study, what I'm looking at people snoring or sleep apnea. So again, in this study, we use a smartphone placed at the bedtime table recording sound, breathing sound. So I'm showing a healthy breathing. So you hear these vertical stripes, that's the breathing event. So that's essentially the sound of breathing. That's when you start to snore. You see that the yellow bit is more energetic region. That's you become the energy more spread out over the frequencies. And the last one is the obstructive sleep apnea. So when essentially people can stop breathing. So sleep apnea has a strong correlation with diabetes. And a lot of people with diabetes have sleep apnea. That's a kind of cause of that. That's kind of both way, I guess. It's very difficult to know which comes first. But that essentially, that's a unique acoustic signature. So when you start snoring and then gradually you stop breathing, then followed by a acoustic event and gasping for air, you essentially wake up. But the problem is you don't remember. This could happen 20 times an hour throughout the night. So it's can be very. You could jump to the next one. There's another study I'm looking at using cough sound for detecting TB and working with African partner. Yeah.
Just carry on.
If you jump to the next slide. So yeah, so basically what we're looking for is we're looking for the potential link between the voice patterns and the blood glucose levels, and aim to develop something that can be low cost, something that you can do at home with ease at any time, using a smartphone. If you jump to the next slide. So the advantage of that, it doesn't require special hardware. So a lot of people have smartphones these days that can record sound, and it's less obstructive. So it's relatively low cost, and it also can allow longitudinal study, tracking of your voice. So every time, this can be kind of actively tracking your voice, or it can be passively looking at your voice. If you jump to the next slide. So what we're looking for is we're looking for volunteers who have a CGM, who can provide short voice recordings. So we're looking at kind of people reading a short passage that will last 30 seconds. So a couple of these kind of passages recording. Then also if you can provide your glucose level at the same time. So it's really what we're looking for. We're looking for potentially 3 recordings throughout the day. So one is kind of normal. We have a normal level of blood level, sugar level. Then one is low, one is high. And we will provide all the necessary instructions. So this will be done, can be done using a phone or using a laptop or tablet. It doesn't require any special software. Move to the next slide. So we just, Oliver just started this project. You managed to record, how many people you recorded so far?
So far, 3 people.
Yeah. 3 people. So we're looking, in this particular study, we're looking for 15 participants. We don't have a lot of money to pay people, but we will provide a £10 Amazon voucher as a gesture for the effort you're going to spend. So, but we hope to get some funding to run PPIE sessions, because we're looking for the voice. You mentioned earlier that's kind of people who don't speak English or people who have accents. So we're very interested in a diverse voice. So we can run potentially a couple of PPIE sessions. So if you jump to the next slide. This is my last slide. So if you're interested, do get in touch with me or scan this QR code or click on the link.
Not the questions, great. I mean, the other thing we want to do, I think we really surface the during class. One can very closely identify the actual glucose. And we are running some clubs in type 2 diabetes. Finished yet. So if you can get the protocol to me quickly, we'll put it through the ethics committee. We can do those. And I'm writing to some friends across the world who are doing clubs maybe as complicated as ours. Although, and the other interesting is high glucose. People don't know this, but once your glucose goes above 15, there's evidence of cognitive impairment above 15. And some of you, when you're high, I say, yeah, that doesn't surprise me at all. But it would be quite interesting with the high glucose.
Yeah.
Or is it more of a blunt form, you're either high or low?
This is exactly what we're looking to answer, whether we can make a very good prediction. So we want to look at some sort of correlation of the voice with the blood sugar levels, and whether we can predict a kind of broad category, low, normal, high, or more kind of detailed prediction. But we very interested looking at the individual voices because there's a lot of differences between people's voice, but we like to look at, for individuals, the changes in your individual voices.
I mean, I think the university in CGM would be maybe the learning years really because if we could way of people. I mean, one thing people do have is a smartphone. The way regular basis. We did a study which we published in VNA in '95, where we showed that if you compare people themselves to their families always recognize or frequently recognize
Yeah.
it may just be they were very young. Did they recognize that much?
Yeah, and children as well. The parents often recognize when children is the voice changes. Yeah.
Can I ask what you've noticed over the years doing hypoglycemia? Do people's voices as they go?
I don't think it's been observant enough. I mean, we very rarely see frank cognitive impairment, although we do detect it from fortuitous reaction. And we find that at a level of 3 millimoles per litre, 3.23, people begin to have prolonged reaction time, choice reaction time, when we have to choose from 4. And then once you get down to 2.5, then of course the numbers increase. So there are clearly some people who resist. And I have to say, sadly, as somebody who's also old, is that your glucose threshold for cognitive impairment rises as you get older. So by the time you're in the late 60s, 70s, your cognitive impairment is occurring probably around 3.5.
Didn't you do a study on reaction time? Right.
This wasn't driving, this was glucose clamp. That was in 65-year-olds comparing to 25-year-olds.
Between 5 and 10, the reaction times are normal.
Yeah. And what was interesting, this was in non-diabetic individuals, so it wasn't the effect of diabetes, it was an aging brain.
Well, it's in the same way as a kind of lie detector. You test whether you've got a bit of tremulousness.
Yeah, they were looking at shimmers, jitters in your voice, shimmers. Yeah, there's different change. There's more kind of acoustics differences, but also that potentially there's a longer term from linguistic point of view.
But if people have CGMs, they won't let themselves go.
They probably won't, although number of people with 10,000 is so amazing. I mean, funny, I wore a CGM when I was using both a tandem system and an OP, and because I didn't have diabetes, my alarm kept going off at 3.8, 3.7. Oh, geez, I'm out of it. When you're sleeping in the spare bedroom till you finish the stupid. And I think people do switch it off because their partners is fed up. Okay, thank you.
Just with these smart cards they've got these days, but fancy technology and cards, is there the someone said that during the first meeting, where you about price, say something on the voice.
It would be fascinating, and people have been interested in doing some kind of test before you set off in the car. I don't think it's ever become commercial, but there's certainly studies which have done that. Actually, yeah, and I think the global health issue might well be something which would be they'd be receptive to this, because I go to India and give talks, and I want to talk about Daphne, which is dirt cheap and it reduces hypoglycemia. Are the doctors interested? Absolutely not. They're just interested in hybrid closed loop and technology. And you want to say, hang on, you guys. Yeah, it's so frustrating. But of course, in India, I'm told you get paid by seeing people. So making people independent of you is a disaster financially for a doctor, because they've got to keep people coming because they earn money. That's how they earn their money. Terrible. Yeah, well, there you are. Okay, thank you very much. That was really great. So I'm going to move quickly through the studies we're doing and how you can participate. Then I'm going to talk a bit about type 2 diabetes, which you might say, well, you know nothing about it. That's absolutely true, but I am finding things which are so scary. So if we could go back to my slides. Okay. Great. So it's just, yeah. So these are the studies we're currently about to start in type 1 diabetes besides CLEAR. One is called SOFIST, and some of you will have heard of SGLT2 inhibitors, which essentially make you pee out glucose. And we were pretty skeptical, but they're really useful, although they do have some side effects, which some of you will have heard of. But essentially, by peeing out glucose, it reduces your glucose, it reduces your circulating blood volume, and they can make you live longer if you have heart failure, which is really interesting. And they've been used mainly in type 2 diabetes, but we want to do a study which was led from my colleagues in Dundee to look at sotagliflozin, which is medication, a SGLT2 inhibitor, to see if in people with type 1 diabetes and who've got a degree of heart failure, we can reduce their symptoms, their quality of life, and their walking distance, and essentially help them possibly to live longer, but improve their quality of life. So that's the study, 18 to 75, type 1 diabetes with a diagnosis of heart failure. It can't be really severe, so it's early heart failure, and we are due to start it in the next month or two. I've just signed the approval. I think it's worth doing. The one important side effect that some of you will have heard of, it can make you go into ketoacidosis if you're not aware that it can happen, and it can happen at a glucose which is not very high. So we will be telling people how they can identify that and making sure that doesn't happen. Really importantly, SGLT2 inhibitors may turn out to prevent kidney damage. And of course, the group we really want to focus on are teenagers and young people who run very high sugars, as many of you will know, because, well, everybody hates diabetes, but they really hate diabetes, type 1. And they often stop their insulin, they run high for a few years, they don't want to use hypoglycemic loop often. And a small group will get kidney damage, which can progress. And it's possible these drugs will protect them. But of course, these drugs can also increase the risk of ketoacidosis, and that's where we see ketoacidosis. So it's kind of an interesting problem for diabetes specialists at the moment. So that's one. The second is called SMILE, and this is looking at what we call adjuvant therapy, additional therapy in type 1 diabetes. And many of you will be aware there's something called dual diabetes, type 1 and type 2. And it's essentially people who put weight on with insulin. Because weight gain is what insulin does. It makes you gain weight. And people who have type 1 diabetes struggle much more with weight than people who don't have diabetes. And if you like, it's the treatment which is aggravating that. And we see many people who are overweight and frankly obese with type 1. It really is damaging to their quality of life, and increases their cardiovascular risk, importantly. And these medications, GLP-1 analogs, which we're going to talk about a bit more shortly, can reduce cardiovascular risk, heart attacks and strokes. And shouldn't we be using them in type 1 diabetes? At the moment, we are using them, but we shouldn't. It's off what we call off-label. It's not been approved. There haven't been many studies. But this is a study which is going to be funded, a research study, to see whether giving semaglutide, Ozempic, is useful. And of course, there are other ones now. And we're going to treat them for 36 weeks, just over 6 months. And we're looking for people aged 10 to 24, type 1 diabetes, HbA1c 53, up to 85. So this is in young people predominantly, teenagers, late teenagers, and I think 24 years. So that's also happening at the kids' hospital as well. So those are 2 studies we're about to start in type 1. Going backwards. And these are the studies that Solomon Tesfaye, sorry, yeah.
So can I just, another one before the softest one?
Yeah.
How did you manage to get agreement for people with type 1 to have that, can't see it, but they.
You mean because of the risks?
Yeah.
Well, interestingly, a lot of people think we should be using them in type 1 diabetes. Some of the companies have stopped marketing them, but in other parts of the world, they are being used. I personally think it should be used with a daily ketone test. I think if you were to measure a blood ketone every morning, it would be safe. In America, that's so expensive that it would wipe out the profits of the companies. Unbelievable. But here it could be done. So I think, of course, we'll be very cautious and careful. But if it makes you live longer with heart failure, isn't that a price worth paying? But you're absolutely right. It's with some anxiety we decided to go in for this, and we've talked a lot about the risks. And we will be honest. People will have to know that that's something they're going to have to look out for. So it's a really good question. Okay, these ones quickly. We've got oceanic, and one of the things that Professor Tesfaye is interested in identifying nerve damage at a very early stage with fancy implements. I've always been very skeptical because I said, okay, Solomon, you're going to find these people. What are you going to do? Oh, I'm going to make sure their glucose is as close to normal as possible. But I said we do that anyway, and he gets cross with me because I said I'm not against it, but if that's what we do anyway, is it worthwhile? And to this day, we don't know whether keeping your glucose close to normal when you already have some nerve damage can prevent it going on. This study will answer that question. So a very important study, which I'm very think it needs to be done. Age 18 to 75, type 2 diabetes, A1C over 60, 7.6%. And also they'll go for blood pressure, cholesterol, and weight. So that's an important study, which we're recruiting. MyFoot is looking to improve heart attacks and strokes in people who've had foot ulcers. If you have had a foot ulcer, your risk of morbidity and mortality goes up. So can they prevent that? So by giving education, physical activity, medication. And the last is Reimagine, and something called CagriSema is a combination of semaglutide, which is effective, and cagrilintide, I think it's called, yeah, cagrilintide, which is another chemical messenger in the body, and they work together. There was a study showing much greater weight loss than with semaglutide at all in the small study. The bigger study hasn't confirmed that, but nevertheless, they're going to look and see if it can help people who have pain in their nerves because of neuropathy. So that's 18 or older, type 2 diabetes, diagnosed for 1 to 6 months with painful diabetic nerve damage. So those are the studies we're recruiting. If any of those are interesting to you, or I might get Sharon to send those to you so you can pass the message on. We're looking for those. I think there are obvious benefits for people in most of these studies, but you have to decide whether the commitment. But as I said at the beginning, and as Lindsay's encouraged me to encourage, participating in these studies does give you a diabetes nurse specialist at the time. That's quite useful sometimes. And we'd be very keen to hear from you.
And the microphone, is it for people not?
No, they shouldn't. It's current or previous foot ulcer. That's not amputation. I don't think. I'll check, but it's a good question. Yeah. Right, let's move on. Type 2 diabetes in youth, you might say, so what? It's just the same disease. As Deb knows much more than me, it's a different disease. What we're talking about here is a very different disease from the type 2 diabetes that those of you who have diabetes have. And it's going up. This is the rate at which it's going. You can see that in 2002, very little, and it's now increasing, particularly in certain ethnic populations, and it is very scary. And if you look at non-Hispanic white in the US, it's virtually flat. But in the other ethnic populations in the US, it's going up. This is the current global prevalence of type 2 diabetes and children. And the other striking thing is that if you look at the white European population at the top, it occurs, but if you go down to the bottom, Brazil, India's not here, but I believe that in India, it's up with Brazil. It's 100 times more common in those countries than it is in Europe. And that is really scary because it causes terrible damage. These are some of the risk factors. Type 2 diabetes developing at late childhood or early adolescence and beyond, a BMI over 85, strong family history of type 2 diabetes, gestational diabetes during their pregnancies, as I've said, certain ethnic minorities, and accompanying insulin resistance. And we think that puberty, with the generation of sex hormones, high testosterone, may be one of the factors which is causing this aggravation. So you've got insulin resistance. The insulin that you produce yourself doesn't work well. And some of you will be aware that in the liver, you can get fat deposited that leads to the insulin not working. And in the pancreas, both fat, but also a protein called amyloid is deposited. And we think they actually obstruct the beta cells from releasing insulin. Lifestyle, resulting beta cell dysfunction, structural racism as well, probably. In utero exposure to diabetes, a genetic component for sure, and possibly environment and pollutants. So those are some of the hypotheses and have been reviewed. The long-term complications are scary, really scary. A lot of hypertension, diabetic kidney disease, which can lead to dialysis and renal failure, dyslipidemia, nerve disease, and microvascular disease, retinopathy. And the amount of complications that we're seeing in the people in their 20s is horrendous. And it's been worked out that by the age of 25, 80% of these young individuals with type 2 diabetes have microvascular complications. I mean, unbelievable. And we have about 30 people in our clinic, adolescent clinic. I saw 2 people yesterday. And look at the difference between type 1, which was always thought to be the really serious problem, and type 2. This is the kidney disease-free survival. In other words, the kidneys being affected in type 1 in black compared to type 2 diabetes. And look at the age. By 20 years old, the difference. And major complications, huge numbers. And look at type 1 diabetes, virtually none. And it shows the prognosis in type 1 has been transformed by much better pediatric care and the technology we have. And yet in type 2 diabetes, disaster. And we have treatment, although it's not yet approved for use. There's only one GLP-1 medication, to my knowledge, that the FDA, that's the Americans, have approved for these people. But these trials are beginning to show that semaglutide and probably Mounjaro are going to work just as well in this group, but we urgently need trials to prove it. They do cause GI side effects, but they reduce weight. And it's really that which matters. And frankly, and I don't like to say this, the idea that you can change lifestyle in these kids is just no hoper. This drug, if you can get them to take it once weekly and put up with the nausea, I suspect will be life-saving. But Deb knows much more about it than me. So this is what's being advised: primary care screening at age 10 or puberty in those who are overweight, particularly HbA1c, possibly a GDT, although frankly an A1C is probably much easier. Refer these people to a diabetic clinic, multidisciplinary clinic. Okay, lifestyle perhaps, but frankly the one that's going to work is going to be at the end. And bariatric surgery is being done, not much in this country, but in the US. So I'm going to just rush through that to tell you this is probably the biggest problem in diabetes now in the UK, and yet we don't have that many. But what is happening in South Asia and in Latin America, I have no idea, because this is going to devastate their countries unless we do something about it. And, you know, these drugs, as GLP-1 and SGLT inhibitors, are not cheap.
What has it suddenly changed then? Why not do?
I don't know. I suppose it's probably weight and nutrition. I think so, because it's difficult to think what else. Pollutants, maybe. Until I read these reviews, but I'm now going to invite Deb to hopefully talk for about 10 minutes, to give us 15 more minutes for discussion.
Yeah.
And because he knows a lot more about it than me. But I think it was covered. Anyway, over to you.
That's okay. Right. So thank you for inviting me, Lindsay. And my name is Deb Kaur. I'm a GP, an academic GP, and I work with big data, national data. And just resonating what Simon has told you about is young onset type 2 diabetes and the challenges we are facing at this moment, not only in the UK, but globally. So just drawing your attention to the title of my talk, which is young onset diabetes poses a greater risk of end-stage kidney disease than myocardial infarction and stroke. Myocardial infarction means heart attack and stroke. And why this topic is important. I will set the scene by just taking you back to the history. Okay, just can you? Is it working? Yeah. Okay, sorry. To set the scene, I will just take you back to 1990, when United Kingdom prospective diabetes study was actually started recruiting patients. And this is the hallmark of all the diabetes intervention we are doing at this moment, because this is the landmark study which told the world that if you can reduce the HbA1c, which is obviously the blood sugar long-term risk of microvascular complication. So kidney is part of microvascular structure, and you have got the nerve and the eyes, retinopathy. These are the three microvascular structure, and you can reduce the risk of microvascular complication by 33%. And that led us to focus on managing glucose, and we are trying absolutely everything to reduce the complication by keeping the blood sugar near normal. We have been doing it, but as a GP, I can see we are actually keeping the blood sugar near normal it has reduced the complication, macrovascular complication, which means heart attack and stroke, but we are seeing microvascular complication is going above the roof. If I give you the figure, Renal Registry UK, which publishes a report every year, and from 2011, they're saying people who develop end-stage kidney disease requiring dialysis or transplant due to diabetes has increased year on year, and about 4.1% increase from 2011 to 2020. So why is it like this? Previously, we used to think that people who develop kidney disease in type 2 diabetes will probably die of cardiovascular disease before progressing to kidney disease. But what we are seeing now is people are surviving longer and they are getting kidney disease and staying on dialysis for a long period of time. And as Simon has said, in Bangladesh, where I come from, the median age of dialysis is 49 years compared to 64 years in the UK. So some parts of the world is suffering from this pandemic quite a lot, and they have not got the infrastructure to support those people. So people are dying from end-stage kidney disease. So the question I'm asking is, what we are seeing now, is it because of younger people developing type 2 diabetes and they are progressing to end-stage kidney disease? And should we actually focus on multifactorial intervention rather than focusing only on keeping the sugar down? We are keeping the sugar down, but we are actually seeing people are developing kidney disease, which is not good. It is devastating. Each dialysis costs the NHS £34,000 per annum. The NHS can't afford it, and therefore we have to do something about it. So I have done some study on UK Biobank, which has got about 502,000 participants, and asking the question, what actually we can do about this. So the research question I had was, is young onset diabetes driving the rising incidence of end-stage kidney disease? We don't know yet. What is the cause for this epidemic? And is ESKD or end-stage kidney disease of a higher likelihood than cardiovascular disease in young onset diabetes? The reason why I'm asking this question is, if you develop heart attack or stroke, if you survive, then we have got a very sort of prescriptive way of treating you for heart attack and stroke. But for end-stage kidney disease, you are on dialysis or transplant, which is very expensive. And we need to know, actually, can we do something about it? Sorry, I just, okay. So obviously I have used the UK Biobank data, which actually shows that there is a linear relationship between the age of diabetes diagnosis and end-stage kidney disease. Is it clear to you, this graph, or do you want me to explain? So if you have got diabetes below the age of 20, you will develop end-stage kidney disease at the age of about 52. And if you develop it at an older age, you have got very little chance of progressing to end-stage kidney disease. So there is a linear relationship. So kids who are getting diabetes at a younger age, they are going to end up with end-stage kidney disease. This graph came from analyzing the data of the UK Biobank, 500,000 people's data. I'm not going to bore you with this. This is basically a forest plot, which basically shows that people who develop diabetes at a younger age, they are at a very high risk of developing end-stage kidney disease, about 5 times, compared to people who develop it at a younger, older age. And also diabetes duration can increase the risk of end-stage kidney disease. So if you develop diabetes at a younger age, you are going to suffer from it for a longer period of time. So you have more, the duration of diabetes will be longer, and you have also got the diabetes at a younger age. Both of them actually increases the risk of end-stage kidney disease. This is a slide which is actually showing us, so it's called scatter plot. I will not bore you with this, but these little dots you can see is something we called albumin. When you start passing albumin in the urine, it's a protein which is actually telling us that your blood vessels are not keeping the protein inside the vessel, so you're leaking protein. It's very easy to do the test in primary care, but it is very important marker for both micro and macrovascular complications. And you can see here, people who develop diabetes at a younger age, they have got a trend, upward trend of passing protein in the urine. Whether we catch it or not, it's a different story, but these people will progress to end-stage kidney disease, or they will also develop a macrovascular disease like coronary heart disease or peripheral artery disease. Similarly, you can see with hypertension, because diabetes and hypertension, they come together, and you can see the relationship with hypertension and urinary albumin excretion is not like this. So we can actually pick those people if we do a simple test, urinary albumin, and we can actually detect those people who are developing what we call vascular damage. And these people, if we can provide multifactorial intervention rather than just focusing on glucose, we can actually prevent the progression of the disease. This is, again, smoking. So we have to look at different things. It's not only sugar. You have to look at the smoking. So people who start, almost 80% of the smokers start smoking at teenage. And you can see what happens to their albumin. So they start passing albumin in the urine if they start smoking, and then it just goes up. Interestingly, current smoker, it goes down. But people who start and stop smoking, they have got different kind of rise. So you stop and start again, and that actually causes oxidative stress. Oxidative stress is basically your lining of the blood vessels become exposed to different chemicals, and that can damage your blood vessel and can cause leakage of the protein in the urine. So this is an indirect marker of what happens when people start and stop smoking.
What is it? So,
Yeah.
is it, so somebody starts smoking
Yeah.
and then gives up? But is that death about people who give up? Or is it about people who
So
give up and then start?
current smoker who has not stopped smoking, and what we're looking at, age of smoking. So they started between this age 10 to 20, maybe about 15 to 18. Their urinary albumin goes up, okay, and then it just plateaus and it drops. Other factors takes over. But when somebody just stops and then starts again, that causes, most important thing is post cessation weight gain. So they start gaining weight, they start eating wrong food when they stopped, and they start again. So they have to, that increases the insulin resistance, and also their glycemic control becomes poor. That's why you can see biphasic rise when you have got stop and start. So if you stop smoking, you should stop and don't start again. And we are failing because a average smoker takes 16 attempts before they can stop. Okay, and I work in most deprived area of the country, and I have seen it. People just say, you have asked me to stop smoking, but my blood sugar was normal. My blood sugar has gone up. But if you think about it, blood sugar is only one part, but smoking is nicotine, carcinogenic. It causes cancer. It directly damages the blood vessels. So you have to look at the bigger picture, and your sugar will come down, but you have to abstain long term. This is what the message is here.
Yeah.
If you think about it, you stop smoking. Smoking helps you keep your weight down. You stop smoking, you gain. Then you start smoking again because you're gaining weight, and it's devastating. So it's the intermittent nature of it, if you like.
And it damages your blood vessels. We have seen it in different studies that
The worst thing you
Yeah.
can do.
yeah, absolutely. No, because your blood vessels are already exposed to blood sugar, which is actually damaging your blood vessels. On top of that, you are giving nicotine, you are giving the smoke and also other materials within smoke, and that's damaging the blood vessels. And stopping and starting is another devastation. This slide is showing there is a little bit of difference between male and female. So this is a stratified analysis. So I looked into actually, is there any sex difference between boys and girls who gets diabetes and hypertension at a younger age? Look at it. Before this is girls who develop type 2 diabetes below the age of 20. they develop end-stage kidney disease at about this age, between 40 to 45, while male develops a little bit later. On the other hand, you can see here, if hypertension, the boys get hypertension, they develop end-stage kidney disease at the age of 40, while girls get a little bit later. We don't know. This is an observation. So we need to do a lot of work to find out what is the sex variation. And like what Simon has said, there is difference in hormone. There is testosterone, estrogen. We don't know what they do to the blood vessels. And growth hormone, this is another hormone you get in teenage years. And on top of that, if you start smoking, which increases the insulin resistance, plus also you have got all these hormones going on, you actually damage your blood vessels. And to be honest with you, it actually damages the small blood vessels more than the bigger blood vessels, like kidney, your eyes, your neuropathy, your nerve vessels. And that's where the problem starts. So I will just bring it to a close. So younger onset diabetes is a contributor to the end-stage kidney disease. Because I have used UK Biobank data, there are some limitations in the data set because it is volunteer data. So it does not represent the real world. And also 94% study participants were white Caucasian. So that means I could not do ethnic stratified analysis because ethnic people are suffering much more than the white people. So at this moment, I'm writing a grant application, and this is where I'm actually trying to do a national data study to look at what is driving it. Okay, so this is the last slide. The type 2 diabetes in young people is a different genetic condition. It's not like polygenic, like different other things that causes type 2 diabetes in adults. Obesity, 95% in case of younger people than compared to 50%. Simon has already mentioned about it. And also we have got what I call vasculitis. The blood vessel becomes inflamed in early stages, and annual decline in beta cells, about 20% in case of younger onset compared to over 7%. So the pancreatic cell which produces insulin, they're damaged much more quickly in younger onset compared to older onset. And the most important thing is we initiate insulin very early stage, and what Simon said makes perfect sense. The GLP-1, SGLT2 inhibitor, irrespective of glucose lowering effect, they're anti-inflammatory. And we are depriving the kids from this. We are focusing on euglycemia, keep the glucose, and we are giving everything to them, and it causes glycemic oscillation. And this is damaging our blood vessels. We must come out from this.
Yeah, this is the scariest thing I've ever read about, and it's happened in the last few years. And yet, GLP-1 analogs, we are transforming an A1C from 80 to 35 within 6 to 8 weeks. These drugs are remarkable, and yet there are very few trial data yet.
Yeah.
And we just need to accumulate it. And I think your point about biobank, white professional middle class is volunteered for biobank, and we really don't know.
Yeah.
But I suspect the story is even worse.
Yeah.
Much worse.
Absolutely. So this is what I'm trying to do, Simon. So I'm accessing the CPRD, about CPRD and NHS data, and this will be a very big study which I'm going to work on. And what actually I would like to see is glycemic management strategy, whether insulin or non-insulin dependent drug, and what actually the progression of the kidney disease and other vascular complications.
Great, thank you. That was a great talk, Brenda. So Brenda, we got 10 more minutes.
Yeah, sorry.
And then I'll be in big trouble if I don't get home by 9. That's right.
Any question? Yeah, sorry.
Glycemic variability.
Yeah.
Because I think we appreciate now that is almost as damaging, if not more damaging than
Yeah. Absolutely. Absolutely.
I've often wondered why.
Yeah. Persistent hyperglycemia gives you a status quo of your endothelium, the lining of the blood vessel, which controls everything. But when you have got like this, there are some different chemicals, because what Simon said is hypoglycemia, it causes oxidative stress. It releases some chemical in your body, and that causes all the problem. And also when you put people on insulin, it is inevitable that they will have this. Plaque, the lipid will go there, bump in the blood vessel, of heart attack. All these things happen, and we are very happy that we are keeping the blood sugar normal. So what? I mean,
Yeah, I mean, the CGM tells.
yeah. So it will show you, because two kind of variability. One is HbA1c variability. So it's long-term sugar. You can go up and down like this, which is I'm not too worried about. But if you have got daily like this, so blood vessels are like a pipe, and this pipe you're damaging the lining and allowing things to happen to it, and that's what heart attack and stroke and kidney problems. Yes.
Does the same happen if your stress is between, say, 4 and 10 or 4 and 14, or is it when it only when it goes above 15 and down below 4?
So Simon is an expert in this. We have done a lot of work on this hypoglycemic and glycemic oscillation. The issue is, if you are like between 3 to 7 or something like this, this is when you start having the very much sort of oxidative stress, which actually put your blood vessel under a lot of pressure. If you are 7 or above, I will not give you an exact figure, but 7 or above, your body probably get used to it. And this is probably not going to react so badly. But when it expects your blood sugar to be between 5 to 6, and you are actually dropping to 3 and then bringing to 8, this is when the blood vessel starts crying out for help.
Because you see, when you go down to 3, 3.5, you're beginning to make adrenaline, a stress hormone.
Yeah.
And we know that that accelerates the thing you're trying to avoid, which is atherosclerosis, you know, fat deposits, plus inflaming the blood vessel.
Yeah.
Trying to set it 4 and 10, say, sometimes got. Is going up and down like that bad? Was it okay?
Well, it depends. I suppose it isn't great, because that is also stressful when your sugar goes above 15, but when it goes down as well, that's equally bad. And of course, the more variable it is, the more likely you are to drift to hypoglycemia. And I spend my life telling everybody that insulin should be prosecuted. It shouldn't be called act rapid. It should be called too slowly, because it doesn't work for half an hour. And nobody believes me. And I said, look at your CGM.
Yeah.
And when you do, you can level it off. But you have to then tell, you know, give insulin half an hour before you eat. Now, who does that? I think it's very difficult. And even on hybrid closed loop, which is easy peasy, you just have to put it into your phone to say you're going to eat. People don't, because they forget, especially teenagers. And so you're not making the most of your hybrid closed loop. Sugar goes up, then the insulin begins to work, your stomach's empty, then you become hypoglycemic. It's so common, and yet people see it on their CGM traces, and they say, well, what's going on here? And it's probably the most common thing that could be fixed, is just injecting half an hour before. Probably the most important thing. Absolutely. I mean, it's a typical doctor thing. It's so impractical. But you know, I think we gaslight people. Insulin's fantastic stuff. You're going to do this. I tell this all the time. You just do what you have to do. You count your carbs, and you can have a normal glucose. Can't. You have to think all the time, half an hour before you eat. And if you don't, you're going to get fluctuating sugars. It's probably, and the only other thing is, when you exercise, you've got to think probably eating carbs is probably the best if you're an MDI. But if you're on a hybrid closed loop, you've got to tell the blooming machine you're going to exercise probably 45 minutes, an hour, even an hour and a half, because that insulin will continue to work for up to 2 hours. But it's hard. I mean, God, I couldn't have diabetes. Impossible.
You know, like, yeah.
Type 1 diabetes is completely transformed. I started doing diabetes in 1981, and I went to Thirsk on a children's camp, 6 to 8-year-olds, testing their urine. And guess what? They all went hypoglycemic in the middle of the night. We ran them high all week, and that was the only way we could survive the week. Look at today, it's completely transformed. Children are coming out, even teenagers, And I'm seeing 90-year-olds and 80-year-olds in my clinic. I never saw anybody barely over 70 when I started. It's a completely different condition. But do you still have to do loads of work? Absolutely. So I think the technology has been fantastic. And I could have talked about cure. There will be a cure for diabetes. We will prevent our kids from getting it in about 15 to 20 years. I'm pretty sure, or certainly will delay them beyond adolescence. And cell therapy, we are starting a phase 3 trial of cell therapy, which will cure diabetes in this country at the moment. And they'll get better and better. There's now 2 companies developing it. So yeah, I mean, I think frankly, if you're over 50, whether you'll get a cure is probably a bit dodgy. But for everybody below that, I think there's a really good chance. It's, and I'll be out of a job, I'll be dead, so it won't really matter. But I do think we're going to see the end of type 1 diabetes, but type 2 diabetes is the big problem.
Yes, I will just chip in, Simon. So basically, we need to stop our children watching television and not going out, and stop eating them crisp, and do a little bit of exercise and check what they're eating, what they're doing. You have to, it's basically calorie intake and calorie output, and like what fatty liver Simon has already said.
I mean, I'm less optimistic about type 2, but we will have drugs which can cure this condition. And in both Lilly and tablet therapy. So you'll go on your injections, you'll lose loads of weight, and they'll get better and better, and then you'll be on a maintenance tablet. I think that's what will have happened. And it could be 20% of the population will be being treated, which is kind of scary, but they'll come down in price. And I think the much worrying thing is what happens in Bangladesh and India and Pakistan and Latin America.
Absolutely.
They are going to be wiped out. I mean, it's so frightening. I don't know what.
And there is no national health service in Bangladesh. So people who can afford dialysis, they will have the treatment. Those who can't afford it, they're just dying without any treatment, and it's shocking. That's why what actually I'm trying to do, Lindsay, is I'm trying to develop a risk prediction model using the genetic and epigenetic and also the cardiometabolic risk factors, and using AI technology. So this is the work I'm doing now at King's College. So this is what is going to happen. We'll make a change.
And the other thing I would say is that I feel so sorry for GPs. You know, 15, 20 years ago, they have metformin, insulin, and gliclazide. That was it. And now they have 15, 20 medications. And they've all been using DPP-4 inhibitors. And now at least they know they're using GLP-1s. It's really hard for GPs, unless you specialize in diabetes. And I think we have just dropped them in it to give them the right therapy. Inhibitors in type 2 diabetes, for example, if you're on a ketogenic diet, you should never go on an SGLT2 inhibitor. It can be lethal. And yet, I wonder how many practice nurses and GPs know that, you know, how to ask for a ketogenic diet before they start. You know, it's those kind of things which are really hard. I think primary care teams are under such pressure now in type 2 diabetes.
Yeah, absolutely.
Anyway, so that's not so hopeful, but the rest will be. Sorry.
So I guess the thing to say is they're not the lifelong cure, are they? Because once you stop, the weight goes straight back.
Absolutely.
We're not really changing kind of thinking behaviours around food, are we? So a lot of these people will end up on lifelong injections.
Well, I think the tablet behavior, people who've been living, you know, in tricky lives, developing lifestyle habits which get them through. And then some smart Alex says, oh, well, you're going to have to go on a 600 calorie diet. Of course, it'll work for 10%. But we mustn't be naive and to think that that's, going to work for everybody.
They may regain their insulin sensitivity through the hepatic insulin sensitivity.
They
if
may.
lose weight.
They
And
may.
then if they're on less insulin, they'll find it easier to keep the weight off.
You'd hope so. You'd hope so. And I think we shouldn't be totally nihilistic, but to these extraordinary drugs, which of course are now reducing cardiovascular risk. They're taking the fat out of the liver. And, our kidney specialist colleagues and our liver colleagues are thinking, oh my God, these are amazing drugs. Of course, all developed in diabetes.
Absolutely.